All right, well, we're going to get started. Welcome, everybody. This is going to be our last grand rounds of the academic season. We go on summer hiatus after this. And to introduce our very special end of the season speaker, I'm going to introduce Dr. Andy Coyle, our residency program director.
All right, thanks, Lynn. So excited to introduce our speaker today for the last grand rounds of our academic year, Dr. Gabby Waclawik. So Gabby is a graduate many times over of UW, a graduate of UW-Madison, a graduate of the School of Medicine and Public Health, graduating with an MD and an MPH as part of the Triumph program. We were very glad that she continued her training here in our residency program, where as a resident, she distinguished herself as an outstanding clinician, researcher, scholar, leader, and really an advocate for our residents, for the program, for our patients, and for our community. As a chief resident, Gabby has been an exceptional leader, a mentor, friend, and advocate for our residents. And our program is certainly better for her having been a chief resident this year. So we are very grateful for all she has done. Her advocacy and scholarship work has focused on health disparities here in Wisconsin and beyond. And I'm very excited to hear her talk today on colorectal cancer screening disparities. So please welcome Dr. Gabby Waclawik as our grand round speaker for today.
Right. Thanks, Andy. All right. So I have no disclosures. A little bit about the outline for today. So we're going to talk about colorectal cancer screening guidelines and modalities. We'll talk more about screening disparities in Wisconsin. And then we'll focus a large chunk of today on geographic colorectal cancer screening disparities in Wisconsin. And we'll end with a framework and strategies to eliminate disparities in colorectal cancer screening and outcomes. The learning objectives align with this, so we'll discuss the modalities. You'll be able to identify disparities, hopefully in Wisconsin by the end of this talk, understand a lot of the nuances to geographic disparity screening in Wisconsin for colorectal cancer, and then really understand that we need to establish the importance of measurement to address colorectal cancer screening disparities and improve health equity in our state. So a little bit of background to start. Colorectal cancer is the second leading cause of cancer-related deaths in Wisconsin. In the past decade, we've seen about 24,000 new cases and 9,000 deaths. Colorectal cancer is the most preventable, yet least prevented cancer due to low uptake of colorectal cancer screening. And about 25% of eligible Wisconsin adults are unscreened in our state. We've also seen a persistent and widening disparity in colorectal cancer incidence and mortality between Black people and white people in the state of Wisconsin. Colorectal cancer incidence and mortality is also higher in rural compared to urban areas. And we think that's mostly due to lower colorectal cancer screening rates in these rural communities. Historically, in our state, we've seen a wide variation in colorectal cancer screening among Wisconsin primary care clinics, ranging within a single clinic or hospital system, 31% to 90% at varying clinics. And what we really see is that our top performing rural clinics in the state are lagging behind our top urban clinics. Here we have some preliminary data that was from 2018, actually, and it's from the Wisconsin Collaborative for Healthcare Quality. At that time, there was public reporting at the clinic level on certain metrics. And what you can see here is, we said from the last slide, is that there's a wide variation of colorectal cancer screening rates between rural clinics themselves and urban clinics as well. More importantly, too, that we'll see is that there's more urban clinics that are reaching that 80% colorectal cancer screening rate as our goal than our top performing rural clinics. So rurality and urbanity are a continuum with different barriers to colorectal cancer screening. We know that significant health disparities exist between these populations. They're not homogeneous, and there's a wide variation existing within and across rural and urban areas. So identifying and defining the distinguishing factors that affect healthcare use across and within rural and urban geographies is really essential for identifying areas that need additional resources. Traditionally, rural and urban definitions have been really limited to very broad descriptions, and that doesn't really capture the difference between them, as you can really see in these four photos. The lack of specificity has really hampered the creation or application of certain and specific policies and programs tailored to the unique needs of a geographic area. In order to reach our national colorectal cancer roundtable goal of 80% screening in every single community, we really need a much more comprehensive measure of geographic disparities. So I want to kind of take a pause here and let's review the current colorectal cancer screening guidelines so that we truly understand what barriers exist for our patients. So in May 2021, we saw a change in the 2016 guidelines. And what really happened is that before we started screening at age 50 to 75 per US Preventative Services Task Force recommendations, but now they expanded that to start at age 45 because they found that there was benefit to screening earlier. We still are ending at age 75 because there's small net benefit to continue screening beyond there. Unless something to consider, especially in your clinic, if adults have never been screened for colorectal cancer before, it would show there's more benefit for those individuals. So also to review the couple of different test modalities. So there's two large, broader categories. There's the direct visualization methods and then the stool-based testing. So for direct visualization, many of you I think are aware of colonoscopy if you haven't had one yourself. Every 10 years, if you have no family history of colorectal cancer and no history of prior polyps personally, you can have a colonoscopy as your colorectal cancer screening. The thing about colonoscopy is it's a one-step approach. So you have the screening, and at the same time, if you see a polyp on the colonoscopy, you can biopsy and intervene. And so it's also diagnostic. Obviously, there's a lot of different barriers for patients. So you need to do the bowel prep before, usually go lightly. There's oftentimes you need anesthesia and sedation. Also, a big part for our patients is transportation to and from the procedure, having someone that can actually drive them because they cannot drive themselves. And then you need to schedule time off for the procedure, whether that's from work or other life responsibilities. Less common methods in the direct visualization category are also flexible sigmoidoscopy and CT colonography, and those can be performed every 5 years, but much less common. In terms of stool-based testing, we have a few different tests. So there's the fecal immunochemical testing, the FIT testing, and then the fecal occult blood test as well, which is out of favor now that we have the FIT testing, and that's every year. And then also every 3 years, you can have the multi-target stool DNA testing. In terms of what this looks like for patients, usually they pick up the kit, they provide the stool sample, and then they have to also drop off the stool sample at a clinic or a different site. The thing to know about the stool-based testing, though, is when those results are abnormal, you need follow-up with colonoscopy to have completed your colorectal cancer screening. So it's not just enough to have a positive result. You have to have the next procedure as well. So this past couple of years, I've had the privilege of working with Dr. Jen Weiss and her research team looking at colorectal cancer screening disparities in Wisconsin. And we're going to talk a lot more about that research today. As part of Dr. Weiss's research, she's been involved with various programming, including the Wisconsin Collaborative for Healthcare Quality, the Health Innovation Program, and then funding from the Wisconsin Partnership Program as part of this Wisconsin Health Disparities Reports. So the purpose of the Wisconsin Health Disparities Report is really to provide more information on disparities in Wisconsin on health outcomes. And we want to use this to inform and accelerate programs working to eliminate disparities. The goal is to identify opportunities for improvement within our state, and then really also to build very important partnerships among stakeholders as well. And then importantly is to track changes over time as things are happening. It's important to review some of the Wisconsin Collaborative for Healthcare Quality definitions of disparities. So they look at kind of 3 broad categories: racial and ethnic disparities. A lot of these definitions come from the Center for Disease Control and Prevention. So classifying race and ethnicity as American Indian or Alaska Native, Asian Pacific Islander, Black, Hispanic or Latino, and white as self-identified mostly by patients. Payer disparities, so looking at different forms of insurance coverage or lack of coverage, whether it's commercial, Medicaid, Medicare, or uninsured or underinsured. And then geographic disparities. So one thing to note is, and we'll talk a lot more about the 2019 report before we move on to newer reports. The geographic disparities category previously was really limited to rural versus urban designations. And then in the more recent reports, we'll explain why we're using a more comprehensive 6-category system. In terms of defining substantial disparities, we see differences in health outcomes and care measures that firstly affect our population groups, especially seen in these primary care settings. So for the purpose of the report, they looked at different thresholds to describe differences in rates. So 0 to 4%, we kind of said that this was no difference between populations. If it was above 5 but under 10, we knew that that had lower rates and that represented some sort of gap or disparity. But if it was greater than 10%, we said that population had much lower rates, and that was a substantial gap or disparity that we should be addressing. In 2019, the report came out with a bunch of different metrics and cancer screening guidelines. And for colorectal cancer, in terms of race and ethnicity disparities, what we saw, there was a gap kind of among the racial and ethnic disparities with white patients or populations at 79%, and then our lowest performing group as Asian Pacific Islander at 68%. And you can see each dot on that line represents a different racial and ethnic group. In terms of screening disparities in Wisconsin by payer, not really surprising, you saw the commercial insurance group as well as the Medicare group performing pretty close to the 80% mark, and a huge about 20% disparities gap for those with who are uninsured or underinsured, and then Medicaid. In terms of rural versus urban disparities, in 2019, there really wasn't a substantial geographic disparities gap that was identified in this report. So urban groups were performing about 79% and the rural group at 75%. But again, this seems very limited by this 2-category system, because when you look back at that 2018 preliminary data, we know that there's a lot more variation between these groups. So that's where we wanted to focus our work. The aim of our study was to examine racial and ethnic disparities and geographic variation in colorectal cancer screening across primary care clinics in Wisconsin, really utilizing this novel 6-category rural-urban geodisparity model that we'll talk about a lot today. So we created this novel 6-category system for this research, and that incorporated information on regional healthcare capacity and health needs in Wisconsin using zip code tabulation areas. That was created specifically for this geodisparity model. We use zip code definitions as defined by AHEC system. There's a slight change though. The category that they classified as rural group 3, which is the really light green, kind of fluorescent green on the screen, was recharacterized as an urban group, given that was from 2014. So rather than a continuous score of disadvantage, which would score a rural disadvantaged area in the same way as an urban disadvantaged area, this model will account for differences in sources of variation within and between rural and urban populations. And that goes beyond economic factors to incorporate information on healthcare capacity and healthcare needs. Specifically, Wisconsin rural-urban geodisparity model can identify levels of health-related advantage as well for rural and urban zip code tabulation areas across the state. So it's going to identify the health-related characteristics of the zip code tabulation areas through factors that most influence healthcare use within the rural and urban geographies. And we'll talk about that more next. So this conceptual model was based on an adapted version of the Anderson behavioral model of health, and that's designed specifically for rural and urban disparities. In order to distinguish unique health-related characteristics of rural and urban groups in Wisconsin, we performed a cluster analysis to identify 6 groups of rural and urban zip code tabulation areas. And that used 11 health characteristics that represented 3 domains. So healthcare capacity, economic status, and health status. For healthcare capacity, we measured it this way. So through shortages of primary care physicians and mental health providers, we know that they limit people's ability to seek essential preventative services and necessary treatments. So Wisconsin counties, both rural and urban, are designated as health professional shortage areas, which affects access to healthcare, we know. So using the data from the health professional shortage areas, healthcare capacity was measured using the number of primary care providers and the number of mental health providers per 100,000 people population for each county in Wisconsin. For economic status, we know very well from the literature that socioeconomic factors are strongly linked to healthcare access and health outcomes. So for example, income affects one's ability to access health promoting goods and services such as nutritious food, medications, medical care. And using data from the American Community Survey, economic status was measured using rates of poverty, unemployment, uninsured, Medicaid enrollment, and educational attainment in each of these zip code tabulation areas. For health status, we know that physical and mental health are key determinants of healthcare need and how much we utilize healthcare services. So health varies by place, so where an individual lives, and it's influenced by conditions in the environment. So access to grocery stores, parks, crime rates, and using data from the behavioral risk factor surveillance system, physical and mental health status were measured using the average number of physically or mentally unhealthy days reported in the past 30 days for each county in Wisconsin. We then came up with these 6 categories from our cluster analysis. So rural underserved, rural advantaged, urban underserved, urban, and urban advantaged. And the zip code tabulation areas and their corresponding categories can be found at this link. There's obviously some limitations to this geodisparity model. So the zip code characteristics, as I mentioned, some of these health characteristics are modeled at the county level and then extrapolated to the zip code level. There's obviously many characteristics that are not included, things like access to healthy foods, incarceration rates, broadband access, and also some exclusions from the zip code population data. So zip codes that have less than 500 people were excluded, PO boxes, organizational zip codes, and then zip codes with missing values for any of these variables. So here we have, excuse me, the list of the 6 categories, and then the number of zip codes that fall into each of the categories. And then listed below, you'll also see the domains that we looked at. So the green dots show that you're better than the state average in that domain, whereas the red dots show that you're performing worse than the state average. Yellow is right at or near the state average. In the underserved categories in both rural and urban, you'll see a majority of red dots. And then the advantaged categories, you'll see more green dots. And here's how the zip codes looked by different groupings within our state. So the blue map here is the 3 rural categories. You'll see they actually kind of take up a majority of the geographic or the locations of the state. And then the kind of brown markings on there is where there was no zip code data excluded from the study. And then the orange map here you can see is the 3 urban groupings with the majority of kind of around Madison, Milwaukee, and the Green Bay area. So then we needed to extract the data. So we looked at the electronic health record and we looked at data over a 10-year time span from 2008 to 2018. And this was reviewed within 14 Wisconsin health systems. The data included colorectal cancer screening test completion. We also were able to get primary care clinic geographic location, and then multiple patient, provider, clinic, and health system characteristics at the encounter level. In terms of inclusion criteria, we used the 50 to 75 year mark as those were the guidelines at the time of the data collection. People who had not had a total colectomy, so you needed a colon to be evaluated for colorectal cancer, and currently managed by one of the health systems. And then completion of colorectal cancer screening was also defined by the guidelines at the time. So FOBT or FIT testing within a year, multi-target stool DNA within 3 years, sigmoidoscopy or CT colonography within 5 years, and then colonoscopy within 10 years. In terms of our data, we then did a multivariate logistic regression performed to predict the colorectal cancer screening completion utilizing our comprehensive 6-category system. So both the models were then also adjusted for variables that accounted for clustering at the clinic level. So some of the patient variables that we adjusted for included age, sex, race, insurance, comorbidities, and healthcare utilization, provider-specific variables such as specialty of the provider, sex, number of patients eligible for colorectal cancer screening in a provider's panel. Clinic variables include a number of providers at a clinic site, distance from clinic to nearest colonoscopy facility, demographics of the population, the surrounding community of that clinic, and then healthcare system variables. So whether it was an academic or a community-based system. In terms of the data or the results, we were over 460,000 patients eligible for colorectal cancer screening in our cohort. These were cared for by over 2,334 primary care providers in 271 primary care clinics across 14 health systems in our state. So a lot of representation across the state. Colorectal cancer screening rate overall for the sample was 79.2%. And as you can recall, our goal was the 80% from the Colorectal Cancer Roundtable guidelines. Here's a picture of the different zip code designations in our 6 categories. But what you'll also see here is the black dots that represent each primary care clinic in our state that was part of our cohort. So we saw a significant variation in our 6 category geodisparity model. What really happened is it unmasked substantially lower odds of completing screening for patients in rural underserved clinics and urban underserved clinics compared to patients at urban advantage clinics. This would have otherwise been missed in a binary rural versus urban analysis. From that, we really wanted to assess, why is that? Why is this happening? So what are these potential modifiers for this geographic variation in colorectal cancer screening? So we then performed an analysis using multiple interaction terms. Really the only significant interaction term with geolocation of a clinic was the percent of patients in a primary care provider's panel that self-identify as non-white. So when we looked at colorectal cancer screenings for race and ethnicity alone or geolocation alone, we saw that non-white patients had lower screening rates compared to white patients. So 70% versus 80% predicted colorectal cancer screening rates. And then patients living in underserved areas had lower screening rates as well. So rural underserved was around 70%, urban underserved at 62%, compared to all the other geolocations. But when we looked at the interaction between race and ethnicity and geolocation, we found that non-white patients in all 3 categories of rural communities had predicted screening rates less than 62%. We also saw that both white and non-white patients living in urban underserved communities had predicted screening rates less than 65%. So when considering the impact of race and ethnicity alone or geolocation alone, non-white patients and patients in underserved areas, both rural and urban, are less likely to complete colorectal cancer screening. The interaction of race and ethnicity and geolocation, as you can see here, shows that non-white patients living in rural areas are even less likely to complete colorectal cancer screening than their white counterparts, as well as compared to non-white patients in urban advantaged and urban areas. So what can we use this data for? Really to create interventions to increase colorectal cancer screening in racial and ethnic minority groups in our state, as it should also address barriers specific to their geolocation. In terms of strengths of this study, so we had a very large cohort representing multiple geographic areas of the state, multiple healthcare systems with patient, provider, and clinic level encounter data. But there's a lot of people who are left out in our cohort that need to be mentioned. Mostly importantly, the American Indian Health Services was not in part of our cohort, nor were the federally qualified health centers in Wisconsin. The healthcare systems that were included in the data set voluntarily give information to the Wisconsin Collaborative for Healthcare Quality, and they're actively engaged in quality improvement efforts. Also, you had to be included in the Wisconsin Collaborative for Healthcare Quality colorectal cancer screening measures. And that means you needed to have 2 primary care provider outpatient visits in 36 months within a particular health system. And one of those visits had to be in the last 24 months. So that really excludes a lot of people who don't have regular access to routine primary care visits And it's a further exclusion of our underserved population in our cohort, unfortunately. What do we want to do with this data and where do we go from here? So we really want to explore the differences between our high-performing rural clinics and our high-performing urban primary care clinics. In our data set, we do have access to the different modalities used for colorectal cancer screening. And so that's our next step, is looking at kind of the differences in that and who utilizes what type of testing. And then of course, we want to engage in qualitative interviews with the community and these clinics as well, to gain their perspective on barriers and things that are successful for them. Dr. Weiss has an American Cancer Society grant to engage more with the Wisconsin rural clinics outside of the Wisconsin Collaborative for Healthcare Quality. And some of those clinics also include rural clinics in Minnesota, Iowa, and Illinois. So kind of to have greater representation within the Midwest as well. And then what we really want to do is develop a compendium of successful colorectal cancer screening strategies utilized in high-performing rural and urban clinics, and kind of disseminate these strategies to other clinics as well. So we recognize that barriers are not just at the clinic level. So we'll take a little bit of time now to talk about framework and strategies to eliminate disparities in colorectal cancer screening outcomes. One way to think about this is to have a really good health equity framework. And I want to highlight 4 different elements here that we should talk about when thinking about health disparities in colorectal cancer screening. So we've talked a lot today about social determinants of health. That includes healthcare access, socioeconomic status, employment, education, housing, where you live, transportation, literacy, language ability, and then structural racism as well. All of these things should be considered when we're talking about measurement of disparities, prioritization, intervention design, and program evaluation. There's also many multi-level influences that are both barriers and facilitators. So we have to think about policies, the community itself, delivery of healthcare, whether that's at the system level, the facility level, the provider level, and also individual person level influences and other modifiable health behaviors. One thing to recognize is the screening process is really a multi-step process. So we have to recognize that the process isn't just the test itself, it includes the risk assessment of our patients. So when they should be getting screening, how often, what age should they start? Screening initiation is just the first step, but you need to also think about regular rescreening. So is there follow-up or diagnostic testing involved, especially with the stool-based testing? And then when these results are abnormal, performing the diagnostic tests, and then treatment surveillance if you find anything. Finally, we have to acknowledge that community engagement is absolutely critical to successful implementation of evidence-based interventions in communities with health disparities. So I want to highlight too some of the policy changes that have happened in the past and things that are on the docket that you guys can voice your opinion on. So we saw with the implementation of the Affordable Care Act that there was a change in cost sharing for preventative services. So plans before 2019 didn't necessarily deem cancer screening as an essential service. And as part of the Affordable Care Act, they were deemed essential. And so we did see in this study by Dr. May that looked from 2008 to 2016, that after the ACA, we saw an increase in colorectal cancer screening in the US overall. Some racial and ethnic disparity groups improved, but otherwise some also persisted. So for a group of Hispanic population that they looked at, they saw an improvement in the disparities gap compared to white patients. In the Asian population, they also saw an improvement in disparities gap compared to the white population. For their Black population in their study compared to the white population, they saw roughly the same disparities gap. So both groups increased, but the disparity remained the same. So it's good. We have to ask, why is this? What still was going on? So despite ACA provisions in 2010 in Medicare, a screening colonoscopy could have been reclassified as diagnostic if a polyp was found. So so-called surprise billing. So if the colonoscopy is performed for follow-up of a positive non-colonoscopy screening test, that also required coinsurance. So an unforeseen cost to the patient as well, and another barrier. Other policies in place. So recently in 2021, we now see that a plan or issuer must cover and may not impose cost sharing with respect to a colonoscopy conducted after a positive non-invasive stool-based screening test. Or direct visualization screening as well for colorectal cancer screening, and that as recommendation by the US Preventative Service Task Force. Wisconsin is also one of the few states that has not expanded Medicaid coverage. And actually, the Wisconsin Legislature's Joint Finance Committee just voted to remove Medicaid expansion funding from the budget proposal in May 2023. Governor Evers has proposed expansion through previous budgets and legislation since the start of his term in 2019, though none have been passed by the Republican-controlled legislature, but would mean a lot for those patients on Medicaid. Finally, when we think about design and implementation of interventions to eliminate disparities, we have to think about the community. So community participatory action research to identify interventions is absolutely critical. And that's the next steps in our study, is to really engage with the community and understand what they need. We have to address structural barriers at all levels. And interventions should really consider the resource needs of health facilities and health communities in order to best serve them. So there's a trial called the Mr. B trial, and that looked at Black men who received patient navigation in their barbershops. Actually something that's going on in Wisconsin. This trial was not in Wisconsin, but were significantly more likely to be screened for colorectal cancer screening in a 6-month period compared to those who were not navigated in the barbershop. And this just shows that there's trusted social hubs and places of information gathering that happen outside of the clinic level. Finally, we should just remember that the best test is the one that gets done well. So the one that gets our patients screened. As previously discussed, we know that structural racism is a factor of existing health disparities. And one thing we can do to improve diversity and inclusion at the provider level is address this. So a recent study showed that in 2018, only 4% of actively practicing gastroenterologists self-identified as Black. There's many society efforts, such as the American College of Gastroenterology, who are really starting to focus efforts towards improving diversity within the field, as well as newer groups that have formed, like the Association of Black Gastroenterologists and Hepatologists, to create a better sense of community and support within the field. There's obviously a lot of work to be done here. And lastly, we know that meaningful engagement strategies, such as storytelling and endorsement by community leaders, can create trust and address misperceptions to help increase community demand for screening. So well before the Oscar slap incident with Will Smith, he really used a celebrity platform as a way to increase colorectal cancer screening awareness in the community. He used video log basically his whole colonoscopy experience, everything from meeting with the physician beforehand, his prep, going in for the procedure, how loopy he was from the anesthesia afterwards. And then also, most importantly, the discussion he had with his physician afterwards about the findings in his colonoscopy and what they would do for follow-up afterwards. And this was on his YouTube channel, which had millions of followers. So really created a lot of awareness and buzz. This also kind of happened around the time of Black Panther, yes, the movie's Black Panther, yeah. Actor Chadwick Boseman and his death from colorectal cancer, early onset colorectal cancer. So a lot of awareness in the community, which was good. Finally, I just want to leave everyone with this quote. So if we can have these conversations and develop policies and practices to address them, then we can start to dismantle the structures that leave certain patient populations at a disadvantage. I really hope that today is just the start of a conversation and that we can continue to work together to reach the 80% goal of colorectal cancer screening in every single community. I'm the last chief of the 4 to give their grand rounds today. So I have a lot of people to thank for this amazing year. First and foremost, Dr. Weiss's research group. Dr. Weiss has recently joined the Department of Medicine Education residency team as the research APD. She's been a phenomenal mentor and really just the poster child for what mentorship and research should look like. And I've been so fortunate to work with her over the last couple of years. And I hope we get to work more together as I start fellowship here. And everyone on her research team who, from the statisticians who's helped me so much understand everything, to everybody else who's provided their valuable knowledge. Of course, the Department of Medicine entire education team, but most importantly, Andy Coyle, thank you very much for giving us this opportunity this year. I know the four of us have just grown immensely from your mentorship, your countless hours of feedback and growth this year through education, leadership, public speaking, and then a lot of personal thanks. I don't think I could have done this year without Ben, who's here today. You've been on this journey with me for a very long time, and I don't think I could do this without your support. Of course, my family who came today, and then the three other people up here. So Sarah, Nadia, and John. I don't think I could have done this year without you guys. You've been a huge light for me this year, both professionally and personally, especially as I welcome my daughter this year. And I don't think I could have done anything without you. So you guys all know that I think you're incredible, and I don't give compliments lightly. So, and that's really it.
For a great talk and a really important call to action. We have time for questions. Anyone want to start us off with a question, comment, perspective? No, well, I have to the chair first. Sorry. Cut you on line. Then Laura's next.
Great talk, really wonderful. Just a more operational question. When you define colorectal screening, is it at any point in their lifetime, or is it up to date with colorectal screening? How do you adjust?
In the cohort, the data cohort? I'll answer this question, then Jen can correct me if I'm wrong. So it really, what we looked is at kind of in 2018, were they up to date on colorectal cancer screening? And so we could look back 10 years. Did they have a colonoscopy in the last 10 years? Did they have a FIT test in the last 10 years? So it was really a one-time look at if they were up to date at that point. And it's a great point. Is it, routine screening, rescreening that they're up to date on? And we don't have that information in our cohort. Okay.
Wonderful talk. Thank you so much for this wonderful summary. One thing I'm thinking about, which your data probably doesn't address, is what happened during the pandemic. And personally, what I can say in my practice is fewer colonoscopies, more Cologuard. I think there's a better screening rate in my patient population now because of more Cologuards being done. I don't know if you have any data about that or any trends that you've been seeing in terms of how colon cancer screening has been affected.
Actually, we looked, so I was part of a project looking at colonoscopy and colorectal cancer screening within our GI department before a vaccine. So actually something I presented at DDW. So thanks for the question, Dr. Zukowski. But pre-vaccine data, actually, interestingly, we saw not only colonoscopies go down, but also all stool-based testing. And I think a lot of that had to do with nobody was going to their primary care provider and getting screening. So nobody really wanted to interface. They didn't even want to go near a hospital or a clinic because of fear of COVID at that time. And since then, we've seen actually an increase in both colonoscopy and FIT or all stool-based testing actually since then. So kind of we're back kind of more towards normalization. I don't know if you've seen anything else kind of more recently after it's been, 3 years of the pandemic. Yeah.
So we do have through WCHQ more updated data throughout the pandemic, and with more healthcare systems, we just haven't downloaded it yet and started looking at it. But internally, when we were as part of the WCHQ Measurement Advisory Committee, we started looking at what happened during the pandemic across all of the participatory systems, and also what happened with lowering the screening age to 45. And so unfortunately, that kind of all happened around the same time. So most healthcare systems, when we look at it, all of our screening rates went down. Everyone went down. And some of it was because the denominator just got so much bigger, because now we're adding people aged 45 to 49 who really haven't even had a chance to start talking to their primary care providers yet about needing screening, but then also because people were just not going to the doctor. And then plus the limitations that we have with this particular data set, we are starting to see things come back up again. But I do agree. I think that as we start looking at the data post-COVID, we are going to see more stool-based testing use than we have before.
Wonderful work, and the health disparities work that you guys are doing, so critical. One question, working with a lot of rural clinics, myself, I see that I guess at a both provider and at a clinic level characteristic, transitions in providers make a huge difference. And I've seen, as we've started a multi-step processes with other conditions, when you have those transitions, you get these gaps, and that I think definitely influences the delivery of the services. So I don't know to what extent your data set or some of the next steps you're doing are going to kind of look at those provider level characteristics, the turnover in the clinics, for example. So I don't know if you have any comments about that, you or Jen.
I don't know. I guess we don't have that information, do we? Yeah, and I'm not exactly sure how you would measure the turnover, because a lot of the data is at the encounter level, specific encounters. So you'd have to measure kind of between encounters in some way.
Yeah, we don't have that itself. But when we do the qualitative interviews, that's an excellent point that we should ask about at the qualitative interviews. So we knew kind of doing this that there were going to be a lot of really interesting points that we weren't going to be able to get from the actual quantitative data set, and that just really highlights the importance of mixed methods research and needing to go out there and ask questions at the ground, like with the people that are at the forefront.
And we have a great question online from one of our interns that I'll read out. So from Frankie, thank you for the great talk, Gabby. Are there other provider level characteristics or patient level characteristics that can help acknowledge the disparity in colorectal cancer screening in rural underserved patients? For example, a patient characteristic might be mistrust of the medical system. So sort of other characteristics that help explain these disparities.
I think that, like, off of what Dr. Weiss was saying with doing the qualitative interviews, and a lot of stuff in the literature out there does look at, mistrust of the system, but also not just mistrust, but misperceptions about colorectal cancer screening. And that's why I think a lot of using community engagement outside of the medical field. So, things like what Will Smith did by advertising his colonoscopy within the community actually can reach a lot more people than we can within the medical field.
Awesome. So another question from the Zoom audience. So from Dr. Cheda, amazing talk. Thank you. Are there variations in type of colorectal cancer screening engaged by different populations? So across kind of these different, 6 categories, was there higher or lower use of things like colonoscopy, stool-based testing, so forth?
That's the data that we have that we're going to be talking about. It isn't our next step of data. So we have that data within our cohort, and it'll be just the next step of looking at that, at the utilization rates of the different types of testing. And to see also within certain populations and certain clinics, is someone utilizing more of the stool-based testing versus colonoscopy, and how they're successful.
One more question online, then I'll get back to the audience here from Dr. Hildebrand. Such important work, noting that the VA has trialed kind of blind mailing Cologuard to veteran patients, and sort of asking if there are other initiatives to that effect happening in Wisconsin or other things that either of you are aware of.
I know that Dr. Fola-May has done a study looking at that, especially in the LA, California area. So it's definitely being done. I'm not sure. I think the primary care providers in this room would have a better understanding if they're doing any sort of blind mailing, but that's definitely been shown as a successful method to increase the stool-based testing for patients for sure.
Thank you so much for your talk, Gabby. You absolutely rocked it, as we knew you would. I was wondering if I could get your practical advice on how to counsel patients and set expectations about insurance coverage. You spoke to that a little bit, but as a very fledgling primary care doctor, wondering if you could speak more to that in terms of a FIT test or a stool-based test that is positive, leading to hopefully a direct visualization test, or a polyp is found in insurance building. Wondering if it really depends on insurance coverage or if you can just speak more to that.
Well, now as the new rollout, it should be that there is the No Surprises Act. And so it should be covered, but before, absolutely. So people would have a positive test result and then they would need a colonoscopy, but they would need to wait to get that colonoscopy so that their next, years of insurance would kick in, and then it could be considered like more screening once that year has passed for that stool-based testing. So that was the issue before. Now it shouldn't be an issue, but again, people have a lot of issues with insurance saying one thing and then another thing happening. So it's hard to counsel, absolutely.
So I'm wondering if you or anybody else has looked at screening rates for other things like breast cancer screening in that same population, and if so, do you find the same disparities and potentially barriers to screening, or is there unique characteristics of colon cancer screening?
So I know that within the Wisconsin Collaborative for Healthcare Quality, as you can see from that 2019 data, they have on breast cancer screening as well and depression screening. So a bunch of different metrics as part of the disparities report. I don't know who's studying it, but Jen would definitely know.
And then chronic disease management metrics as well, and found that there was a very high concordance between primary care providers' breast cancer screening rates for their panel and colon cancer screening rates for their panel. And we had thought maybe there'd be a discordance in some of the chronic disease management metrics because they're just so different than preventive care versus chronic disease management, but there really wasn't. It wasn't a huge discordance. And our hypothesis is that breast cancer screening and colorectal cancer screening processes really happen outside of the clinic visit. And so there's a reason why those two things really go together. That is, the order is potentially placed during the clinic visit, but what actually happens and how it gets done is outside of that visit.
So, Gabby, well done. So you focus on colorectal cancer, but this kind of disparities are across the whole healthcare delivery system. And like if you live in northern Wisconsin and you have no insurance, you have Medicaid, getting dental care is almost impossible. Like in neurology, we see dramatic correlation between, let's say, strokes and periodontal care. People have bad gums, bad periodontal kind of conditions, have more strokes. So. But the question I have, as you know, I'm a strong proponent of single payer system. Do you have any comparison data from, let's say, Canada? The Canadian system kind of is a single payer. They have this rural city kind of communities. How this compares in terms of this kind of screening, and maybe some data from Scandinavian countries like advanced Scandinavia, like Denmark, Norway, Sweden, how they do it, and okay.
So what I know, actually, there are studies, some out of Canada, also Australia as well, which has in some ways a similar, some urban city hubs, but then a very large geographic area of rural populations. And even pre-pandemic, so we started using telehealth more in our clinics here, but they've been doing that for a long time in terms of outreach. And so they've seen improvement in that sense, that these rural areas, whether it was in colorectal cancer screening, or even mostly a lot of the data comes from inflammatory bowel disease, actually follow-up, that telehealth can be a really successful way to do community outreach in these rural areas. In the Scandinavia, I know we talked about the Nordic trials. I recently saw at DDW, but you could speak more about that. You know more about the Nordic trial than I do.
A lot of these larger single payer countries is also a lack of resources with respect to doing the direct visualization tests. So they don't do as many colonoscopies as they do with, they use more stool-based tests, but it's also more of a population-based screening program as opposed to an opportunistic screening program. So in the United States, we use kind of an opportunistic screening program where like the patient comes to you, you take care of them, you then offer the screening. Whereas a lot of these other countries are they're doing a lot of mailing. So they mail out invitations at the population level to participate in screening, which you'd think would be better. But I think because of that, their denominators are bigger than what we're really measuring here in the United States. And so comparatively, their overall screening rates actually look worse than what we do in the United States. But I really think it's because we're selecting our denominator a lot more. So they're basically just mailing, they're considering everyone and that's eligible based on age as being in their denominator, and then mailing out the invitations to participate in stool-based tests versus colonoscopy. And they don't get as high screening rates as we do. But again, I think it's because of just who they're counting in their denominator.
I think there's probably no kind of counseling too on individualized risk assessment. So whether that person has a family history, which you need to talk to your physician about, if they have a prior history of polyps, population kind of approach would miss that as well.
Thank you so much for your talk. Just this conversation specifically about telehealth reminds me of a news story I heard this morning that our Republican legislature has also denied the funding for greater broadband access in the state. And I'm wondering, and I'm inspired by your talk and your call to action. So I'm curious, like if you would ask us to do one thing that we could just advocate or do something to make this a little bit better, what would your advice be?
Voting is an easy one. Go vote, call your representatives. I think we as physicians have a voice and we should use it.
Outstanding. I think that's a perfect way to end. I think a terrific talk by Gabby highlighting really important, influential, sort of outstanding research work. I think important lessons for colorectal cancer screening, but I think important lessons for health equity more generally, the way we as physicians approach patient care and the way we as residents of the state of Wisconsin approach systematic change. So please join me in thanking Gabby for a terrific talk today. Thank you, everyone.